Over the last 7 years, this lecture has gotten much easier to give. The first time I gave this lecture, in 2014, students were just not ready to hear it. Some walked out of the classroom and dropped the course. Some attempted to disrupt the class by interrupting, with results of random Google searches that appeared to agree with their disagreement of the facts. Some glared and shook their heads in disapproval. One student booed, one student laughed. Some went on to disrupt future lectures by coming in late with joints behind their ears and talking loudly during lectures, and this lecture is halfway through the term. They had not done that previously. Two older students, who were at least older than me, described the class after that lecture, or after this lecture, as weirdly tense and as kind of proving your point about executive functioning. I have given intellectually honest lectures on such politically and emotionally fraught topics as race and IQ, gender dysphoria, religious radicalization, reasons why people torture, murder, and rape, and the factual misrepresentations in activist scholarship. Yet somehow, the lecture where I tell young people that a thing that they like is not good for them has been my most contentious. But as I say, this lecture has gotten easier to give, because, gradually, the more popular textbooks, government information packets, and internet in general have begun to catch up with the information I'm about to relay. In fact, now, this content might not be surprising to any of you. That would be cultural and educational progress, which I hope this lecture can contribute to. Let's start with some positive notes, since for the average user, cannabis compares quite favorably to the substances covered so far: opioids, alcohol, and nicotine. Later, we will see the importance of noting that this is for the average user. Some of us have vulnerabilities that others do not. Cannabis is uniquely useful as a therapeutic tool in some specialized contexts. Some chemotherapies, for example, destroy patients' appetites, and medicinal marijuana is one of the few things that can get these individuals to eat. In this case, the substance is an antiemetic, and it may be saving lives. There is a special kind of pain called neuropathic pain, which is pain that originates from within the nervous system itself, i.e. it does not stem from an outside source. This particular type of pain is unresponsive even to opioids, yet the action of cannabinoids on those neurons may reduce that pain. Cannabis was part of ancient Chinese medicine, dating back more than 2,000 years, and for select uses, it may be the best option. Keeping in mind that these numbers here will A, likely require updating, but B, not change too much over the next few years, we can add a row to our prevalence table. A few numbers are relevant to determining what we put here in this empty cell. Approximately 10% of individuals who have ever used cannabis will become dependent, and people who progress to daily use have about a 50% probability of becoming dependent. And this use of the word dependent is actually an artifact of the DSM-4 diagnostic criteria for addiction. It doesn't mean chemical dependence per se, it just means meeting threshold for DSM-4 diagnosis of cannabis dependence disorder. To get a dependency rate value for this cell that compares apples to apples and fits well with our table, we will use findings from several longitudinal studies that indicate an overall risk of cannabis users developing dependence of 20 to 25%. None of those numbers, 10%, 50%, 20 to 25%, none of those numbers give us the population prevalence, i.e. the percent of all Canadians we can expect to have cannabis use disorder. Since, though, we can assume that all dependent users are regular users, we can get numbers for alcohol and tobacco to compare to this 20 to 25% estimate by simply dividing the dependent users per 100 by the regular users per 100. This is not necessarily perfect and it's sloppy, but it's something. This gives us a more precisely quantified look at just how much more addictive nicotine is than alcohol, and we can now see how addictive current-day marijuana appears to be as well. Following the same algebra, we can fill in the empty cell now by multiplying 25% by 0.2 and by 0.25, giving us the range for the estimated number of Canadians we can expect to be addicted to cannabis in a given year. The lower rate of use and lower addictiveness combine with cannabis to make the prevalence of cannabis addiction in Canada relatively low. Note that there are huge differences in risk factors determining who develops addiction. Starting to smoke weed earlier increases likelihood of becoming addicted. Females tend to develop addiction faster, though they develop it a lot less frequently. And those with anxiety, depressive, psychotic, and externalizing disorders seem more likely to develop addiction as well. Behavioral and psychosocial risk factors for developing addiction include friends with positive attitudes toward cannabis, use of it to cope with negative emotions, concurrent use of tobacco, living alone, and any major life stressors. Alcohol is the substance that the most Canadians are addicted to, followed by tobacco. Then, with a much lower rate, but still third place, comes cannabis. The increase in THC concentrations in the last few decades was covered in Lecture 2. Worth recalling here, though, is the fact that higher levels of THC tend to mean fewer therapeutic benefits, in part from CBD, cannabidiol, being traded out for higher THC, and worse interaction also with existing or potentiated mental illness. This shows the steadily increasing demand for treatment for cannabis use disorder in several European countries. The linear positive slope looks a lot like the linear positive slope from the U.S. Drug Enforcement Agency's THC concentration tests. In fact, the EU report does list potency increases as one explanation for the rising demand for treatment. Treatment in outpatient programs would involve cognitive behavioral therapy, relapse prevention training, motivational enhancement therapy, contingency management, but clients are very vulnerable to relapse. This is true of addictions in general, including cannabis use disorder. Withdrawal symptoms would be a motivating factor to seek help and a possible trigger for relapse even after detox. The cannabis withdrawal profile is actually quite similar to that of nicotine and includes irritability, anxiety, depressed mood, sleep disturbances, aggressiveness, and decreased appetite. Note the higher rate here of male cases of addiction, something you have likely noticed already across all of the addictions that we've looked at so far. Recalling Lecture 2, Toronto Police Services, for example, has institutionalized 4 weeks, 28 days, as the time that it takes to sober up from cannabis use. So if an officer has been found to have used cannabis, she or he is expected to absent themselves from work for 28 days so as not to be working under the acute effects of the substance. That said, a reasonable case can be made that there are longer-term effects as well. The general observation is that with initial heavy use, we see decreases in gray matter volume, but increases in white matter, connectivity. So some cell body death, but some connectivity increase. Yet with longer-term heavy use, we see a decrease in this connectivity as well. And the explanation is pretty simple. Heavy use kills brain cells. The killed brain cells lead to compensation for those lost cells through more connectivity. But if you have enough lost cells, your capacity for connectivity goes down as well, so eventually you start losing white matter as well, because your ability to compensate is limited. Let's use this 2015 study as our guide through some of the brain regions damaged by cannabis use and the more well-established consequences of this damage. Keep in mind that the effects described here are much more severe for younger users, because up to the age of 25 there are still rather major neural architectural changes being made, and use in this period impacts those changes. The damage is worse and less reversible the younger the users are. First, blood flow, the literal lifeblood of the brain. Not surprisingly, the acute effects of THC on the brain, that is, the effects when one is high, are generally to increase blood flow to various brain regions, including prefrontal areas. This swirl of simultaneously firing neurons might be why some people, before they develop tolerance, feel creative and derive more pleasure from music when high. But if you want to do anything halfway complex with this cool superpower you experience, the high brain chokes. The complex task triggers a switch from higher than average blood flow to lower than average blood flow, at least in select attentional regions that you actually need for the task. And performance is worse than when sober. If you have ever tried to actually accomplish something that requires sustained effort when high, you may have noticed having difficulty with complexity. This is why I quit smoking weed in high school after a few months of regular use. I couldn't even follow a Stephen Leacock story, never mind a philosophy book. Those high on cannabis perform worse on tasks that involve sustained attention, including simple tasks like dichotic listening to one message in your left ear while ignoring another message sent to your right ear. Working memory tasks, like keeping track of the last 4 numbers being read to you, or looking for targets in a changing environment. For some reason, when the cannabis-exposed brain encounters focused attention tasks, the blood flow in attentional networks is lower than average, and this correlates to worse accuracy, slower performance, and sometimes subjective complaints about the task itself. There are a host of qualifiers here about specific brain regions, but to sum up, when one is high on cannabis, cerebral blood flow is higher, unless one is performing a sustained attention task, in which case it is lower in attention-relevant regions. What about chronic effects? The chronic effect of frequent use is a reduction in blood flow to the prefrontal cortex. That is, the lasting effect of regular use is to have less blood flow to the prefrontal cortex areas. With regular cannabis use, the blood flow to prefrontal cortical areas is reduced. Blood not getting to control areas is likely related to the reduced prefrontal brain volume and connectivity already mentioned. There is nuance to the executive functioning findings, but generally, cannabis users might be expected to do as well as non-users on attentional tasks if they are simple tasks that are not reward-driven. One study found that cannabis users were as good as non-users at determining which of two card decks averaged higher-value cards, unless a monetary reward was on the line. In the reward condition, the cannabis user's performance went down. We know they can do it, but for some reason, the reward decreased performance. 3 explanations here are motivation, cognitive load, and neural organization. For the motivation model, reward pathway changes in cannabis users reduce the motivation to respond to reward-based tasks. Users perform worse because the reward means less to them. That is certainly a relevant part of the cannabis use profile. There is also a cognitive load or cognitive reserve hypothesis here that says keeping track of additional things like a reward makes the task relatively more difficult for those with less cognitive reserve to keep track of all of the things. And a third explanation is neural organization. This is presented, among other places, in the work of U of Ottawa professor Andra Smith, who tends to conclude the problem is organizational. Her work finds that even on simple executive functioning tasks, the brains of marijuana users do much more than non-users. They do more work. They're lit up more than the brains of non-users. This 2020 study by her group looked at users and non-users aged 19 to 21 years. Keep in mind that these results are when subjects are not under the influence, so these are chronic effects. She and her team attribute the neural differences, i.e. the cannabis user's brain doing more work to complete the same task, to the brain compensating for poorer brain organization resulting from use when the brain was or is still developing. The literature she and her team is pulling from is pretty deep, as research on younger populations appears to be much more motivated and well-funded than cannabis research on older populations. There are plenty of newer studies that cite these studies listed here as well. The most replicated behavioral and performance findings related to these neurological findings are decrements in memory and attention. This includes performance decrements on even simple inhibition tasks like hitting a spacebar only when you see the letter X, which are tasks used as diagnostic and assessment tools for things like ADHD as well. If you have played a game of red light, green light, or Simon Says, you are familiar with response inhibition tasks. It is easy for us to make the mistake when someone says, clap your hands, of not checking first to recall whether they said Simon Says. When high on cannabis, we make more such errors on response inhibition tasks. We have what is called poor inhibitory control, or at least relatively poor, compared to matched non-users. This poor inhibitory control is also a chronic effect of cannabis use. Poorer relative performance on Stroop tests, on go-no-go tests, and other response inhibition measures are some of the most replicated findings regarding chronic cannabis use. But of course, what we care about isn't whether someone can play Simon Says or hit a spacebar when they see an X. We are interested in, more generally, the harm done to complex cognition. Complex cognition can refer simply to the work of doing something novel, tasks that are not straightforward, that require a change of the rules at some point, or bringing several abstractions together, could all be called complex cognition. They are mediated by the prefrontal cortex, and some, but not all, complex cognition tasks are more work for cannabis users' brains, and we see dose-response relations. Performance tends to be worse where use is higher. In decision-making tasks, especially motivated responding ones, the relation between use and poor performance is stronger for males, while females show stronger relations between use and poor episodic memory, which is a hippocampal problem. Speaking of being female, please don't use marijuana when you are pregnant. These are some of the expectable outcomes here that you could expect for your child if you do. I have seen these outcomes in the neonatal follow-up clinic at Sunnybrook Hospital, and they make me sad, and they make the parents scared. Some of these effects we understand at a biological level. Low birth weight is a big factor here, and growth restriction during fetus development is probably due to activation of placental cannabinoid CB1 receptors. This activation decreases the nutrition and oxygen available to the fetus, making it not starved, but not as nourished as it would otherwise be, leading to low birth weight and all the risks that come along with low birth weight. Also, if you're breastfeeding, cannabis will get into your milk supply. I don't know how much harm it does, but let's not find out. One student told me that she thinks her child's explosive aggression is due to her having smoked weed while breastfeeding, and it breaks my heart to think that she might never forgive herself. I told her it would do her no good to think about it and to blame herself, and that it's probably just an illusory correlation on her part. The truth is, though, that it's too late for her. She has the child that she made. If it's not too late for you, please do the right thing. If it is too late for you, please don't blame yourself, because life is too short. And grandparents are correct when they say that most of the things we worry about as parents turn out to be minor and temporary. But now back to our regularly scheduled program. These are longitudinal studies, so when noting these cognitive and emotional problems, keep in mind that most of this data, being from a decade or two ago, is from far, far less potent strains of marijuana than are around today. Many of these findings are the effects of marijuana at THC concentrations an order of magnitude weaker than today's cannabis. Just one joint today would be equivalent to 10 in the 90s. Expect far greater risk for these outcomes today than we had even a few years ago. Moving on to memory effects, let's skip the acute effects here. Memory is poor when you're high, and well, there's an exception of state or context-dependent memory. That is, you might be better able to remember things that happened when you were high when you are high. Okay, done. Chronic effects now. In 1998, Chan and colleagues experimented with slices of hippocampus, which is the area of our brains with the largest concentration of cannabinoid receptors, and which is also the area responsible for memory consolidation and what you could call caching, or accessing memories. Chan found that THC concentrations, equivalent to those in someone who has recently smoked, specifically 0.5 to 1 micromole, were enough to kill hippocampal cells. In other words, THC is neurotoxic at a typical use concentration level. If this were true, we should be able to see volume reductions in the hippocampus and other cannabinoid receptor-rich areas. And we do. And there should be a dose-response relation. Heavier use should predict more lost regional volume. And it does. In terms of performance, hippocampal damage leads to difficulty consolidating memories, especially episodic ones, memories for things that you've experienced, keeping track of a topic or an idea, accessing short-term memory information, which I called caching earlier, and moving short-term memories to long-term memory. But let's not get too pessimistic here. The hippocampus can grow new neurons, so before you fear for your brain or that of a loved one, know that much of the memory ability that is lost is recovered, maybe after a month of abstinence, maybe after 24 months of abstinence. Sobriety brings improvements. That doesn't mean that there are no longer-term or even permanent chronic effects. To the very general question of how long does it take me to get my brain back after quitting cannabis, the answers vary. 28 days, a year, 2 years. If you are only 2 weeks sober, though, expect to still have impairments in many cognitive domains. Attention, ability to concentrate, executive functions, verbal learning, memory, and psychomotor performance. But as for which things you get back and which you might not, consult this table from my favorite psychopharmacology textbook, which could probably stand to be updated and elaborated, but it at least covers things at a high level while faithfully capturing the fuzz in the research. Also, before we leave the hippocampus, I should point out that hippocampal volume and memory performance results may not be due to the neurotoxic effects of THC. Cannabinoids inhibit the induction of long-term potentiation, the creation of new connections in the hippocampal CA1 area. That means cannabis prevents hippocampal growth, so the reduction in volume may simply be a lack of growth or of replenishment of naturally dying cells, rather than cell death due to toxicity. The difference might not matter too much, but it's there. Okay, zooming out, In the understated but concise language of the 2017 National Academies of Sciences, Engineering, and Medicine report, there is moderate evidence of a statistical association between cannabis use and impairment in the cognitive domains of learning, memory, and attention. And these effects translate to the real world. Cannabis use longitudinally predicts a lower chance of graduating post-secondary, a lower GPA among successful graduates, and lower rates of employment for successful graduates, with higher use predicting lower chances of employment. This is where we hopefully have a relatable segue to something called amotivational syndrome. The name explains it pretty well. It is a clinically significant absence of motivation. Amotivational syndrome is an especially well-established finding in the clinical literature, where more chronic or heavier users of cannabis are more likely to be seen. Imaging studies, especially positron emission tomography studies, have shown that chronic use of cannabis is associated with and may have caused substantially impaired dopaminergic function in the striatum. This likely plays a role in not just amotivational syndrome, but also long-term disturbances in mood and cognition. The endocannabinoid system is more complex than just its relation to dopamine, though. That is, exogenous cannabinoids change not just the dopaminergic, but also the glutamatergic and GABA systems. Glutamate is the big source of long-term potentiation, the growth of synapses to make new connections. So there's plenty of interest in how exogenous cannabis disrupts this system as well. But the relation of cannabis to dopamine, or the dopamine system, is nearly identical to how opioids relate to it. If you recall, an opioid increases dopamine not by activating dopamine pathways itself, but by inhibiting the GABA neurons that normally inhibit the dopamine systems, freeing them up to play rock and roll. The THC in cannabis, working on cannabinoid 1 receptors, does the same. A neural system responding to this action might upregulate GABA, because clearly the current amount isn't working, or it might misread tonic as phasic dopamine, and either way, it would inhibit the maintenance doses of dopamine that normally give life and everyday tasks meaning, and inhibiting this would reduce motivation. Since it's been a while since we've seen a picture of a brain, here are some regional volume differences associated with amotivational symptoms in cannabis users. And if you really want to jump into the river of amotivational syndrome and get carried off who knows where, here is Volkow and colleagues captured mid-thought with some relevant references. Amotivational syndrome is serious enough that one can find plenty of guidance advising those working with comorbid disorders to prioritize treating cannabis use disorder, or at least screening for it, because the amotivation will otherwise block therapeutic progress if it's not dealt with. Relevant here are other reasons presented for treating cannabis disorder first, such as the recovery of cognitive functioning to get the client back up to the level of functioning required for active participation in therapy, and to rule out the possibility that comorbid psychiatric issues may stem from the effects of cannabis on emotional functioning. In other words, taking care of the cannabis use might take care of the other problems even when they're quite severe. Since I always get asked, the answer is yes. Some people are vulnerable to psychotic reactions to cannabis, even on their first use. And yes, it may be the case that full-blown schizophrenia, the kind that stays after sobering up, can result from cannabis use. We generally shy away from that last interpretation of the data, but I think it's unfair to vulnerable people to say maybe your schizophrenia caused your use. Especially to the people who, by a straightforward reading of this graph, could lose years of healthy non-psychotic functioning by using cannabis, even if they were destined to get schizophrenia anyway. That is, even if we assume that all the cannabis users who develop schizophrenia would have developed it anyway, we can still clearly see that cannabis is associated with developing schizophrenia earlier. I see nothing wrong with warning people that cannabis leads to schizophrenia in vulnerable people. We know it creates the individual symptoms of psychosis. See, for example, the DSM-5's cannabis-induced psychosis. We know it hastens onset of clinically significant dysfunction, as just shown, so I see nothing wrong with saying cannabis use can cause, or if you still want to be cautious, can potentiate psychotic disorders. It is also associated with the creation or exacerbation of other psychiatric symptoms of bipolar, depressive, and anxiety disorders. But be mindful that the symptoms you are seeing might be the withdrawal profile if the client is cutting back on their use. Okay, 2 more things to cover. The most cited study of cannabis effects on IQ, it's a good one, and what the government of Canada is finally saying about cannabis that I had been literally booed for saying half a dozen years before. Here is Madeline Meyer's longitudinal IQ study. In her sample are nearly all of the children born in the New Zealand town of Dunedin over the course of a year. And please note that year, 1972 to 73, and what it means for the THC potencies, which would be about 1, maybe 2%. Every 2 to 6 years, her team assessed the self-reported behaviors, IQ, and psychiatric well-being of these participants. To see how amazing her participant retention rates were, they started with 1,037 kids at age 5, and 33 years later, 964 of them came back for testing. But her team didn't just ask the participants about themselves, they also had the participants nominate informants who the team asked about how well the participant was doing. I think it's especially nice that participants were allowed to choose their own informant, rather than by default making it the guardian or something. Our baseline comparison point is the 242 participants who never used cannabis and never met DSM threshold for use disorder. They averaged an IQ increase of 0.05 standard deviations, or 0.75 IQ points, to age 38. Added here are the 479 who reported using cannabis but never met criteria for dependence. They saw an average loss of 0.7 standard deviations, 1.05 IQ points. Notice here that the participants are being compared to their own previous score. So if you started out with a low IQ, that doesn't matter. What matters is whether or how your personal IQ changed. Next, we add the 80 participants who only met criteria for dependence once. That is, only at one of the 5 adult follow-up testing sessions were they threshold for cannabis use disorder diagnosis. Their average IQ dropped 0.11 standard deviations, or 1.65 IQ points on average. Next, we have the 35 who met criteria for dependence twice. This group's IQ dropped 0.17 standard deviations, 2.55 IQ points on average. So there's a trend, but it's not very impressive until we have the 38 participants who met criteria for use disorder in 3 or more of their 5 adult visits. Their average IQ dropped 0.38 standard deviations, or 5.7 IQ points on average. Some things to note include the fact that controlling for education level yields the same result, so it's not due to participants not getting higher education. Another thing to note is that much of this result may be driven by adolescent use. If we look at participants who started using early versus those who did not, this shows us the participants who did not use weekly before age 18. They did not show statistically significant IQ decreases, and this is regardless of whether they were frequent left or infrequent right users. Infrequent here means 1 or fewer times per week, and frequent use here means 100 or more times per year. This shows us those who did use weekly before age 18. Infrequent users do show an IQ decrement, but it is not statistically significant. Frequent users are showing statistically significant IQ decreases, averaging 8 points. Specifically, frequent cannabis users who also started use before age 18 see the largest decrement in IQ, averaging 8 IQ points. Worth noting again here is that the participants were compared to themselves. Their IQs went down from where they each individually started by 8 IQ points on average. With that in mind, let's look at what the informants had to say. Informants were nominated by the participants themselves as people who knew them well. They answered quantitative questions about the participants' memory and attention, and these responses were statistically adjusted according to the participants' individual childhood IQ, so things were as fair as we could make it. The results showed that the informants were as good as the IQ tests. They noticed the increased attentional and memory problems in the more dependent participants. In other words, informants noticed the 5.7 or 8 IQ point loss in the participants. I'm going to put the Government of Canada quotes after the outro. Your homework is to figure out what the THC potencies would have been at the different stages of this 38-year study. What concentrations were these participants exposed to in their adolescence and adulthood that led to these specific use-related declines in IQ? And what does that mean for us now? That's enough for now. Stay tuned.
No one's gone.